blood cell goes from being round and donut shaped to forming these jagged, misshapen, weird kind of shapes, which under the microscope can look like a sickle, hence the name. These sickle cells then can become very easily caught in our tiny blood vessels. It basically forms what's called an occlusion. It kind of gets clotted up or jammed in a blood vessel. This then cuts off the flow of oxygen and blood to tissues that are in need. I, as an individual with the disease, I experience that cutoff in oxygen and blood as severe pain because the tissue is being starved in essence, and it becomes damaged.
NICHQ is a quality improvement organization that's based in Boston. NICHQ has a program called the Working to Improve Sickle Cell Healthcare program, which is comprised of 2 HRSA-funded programs, the Sickle Cell Treatment Demonstration Project and the Sickle Cell Disease Newborn Screening Program. The focus is really to improve the quality of care for individuals with sickle cell disease and trait across the lifespan. We know that from the literature that there are several gaps in the quality of care that individuals with sickle cell disease receive. And so we know that effective strategies are not being widely used. We also know that there's differential access to care for individuals with sickle cell disease. And so our hope is that with this project that we'll begin to be able to narrow that gap in the care that's being delivered.
That makes the condition so challenging is that the pain that we have as persons with sickle cell disease, it's a pain that no one can see, no one can observe. There's no blood test that a physician can do that says, oh yes, you Carlton Haywood are in pain, or yes, this is how much pain you're having.
We need to make sure that our patients, no matter where they go, whether it's the infusion center, whether it's the adult ED, whether it's the pediatric emergency department, that those patients are able to receive first-rate care, quick care, get pain under control in as fast a time as possible to really be able to make a difference in alleviating the suffering of our patients.
The reason that we transitioned from pediatric to adult care for children with sickle cell disease is because in sickle cell disease, 20 years ago, the major area of concern was infant mortality. The average lifespan for people with sickle cell disease was 20 years old at the time. And the highest mortality rate was during infancy, and it was from sepsis. And the wonderful thing about it is that we have now improved care with the use of penicillin and newborn screening and childhood immunizations. And so most of the children are living into adulthood. And now the new area of vulnerability and morbidity and mortality in children with sickle cell disease is the transition from pediatric to adult care. So our young adults are the ones who now have a very high mortality and morbidity rate. A lot of young adults use the emergency room as their point of care. And so what we're doing is everyone who is seen in the emergency room within the last month, that our transition nurse case manager is calling them to make sure they have a follow-up appointment with their hematologist. If they don't have a hematologist, she is offering to make appointments at our clinic with them. And so far, she has captured 6 young adults who were lost to follow-up. In other words, they didn't have an adult hematologist, they didn't have a primary care physician, and they were out of the healthcare loop.
this project has begun, we have standardized the way that newborn screening results are entered for both sickle cell disease and sickle cell trait. And the other big initiative is that we are currently uploading educational materials for both the primary care provider and the parents so that they can be printed out and given to the parents at the time that the diagnosis is received. One of the most powerful features of this collaborative is that we are sharing results and ideas in real time. Generally in research, it will take you 18 months to maybe 5 years to start a project, implement it, analyze the results, and publish it. By doing a collaborative such as this, we are sharing ideas, learning what has worked and not worked across the country. Maybe others have already tried this idea, and what we're doing is we're getting to better, more innovative ideas that work faster.
Providers from across the country are able to talk about their efforts and what's working and what's not, and successes and failures to help inform others' efforts. And I think it's going to go a long way to not only talking about what each of us is doing, but what we're all doing together, and what that impact is on the patients we're serving.